You have 6 minutes altogether, please.
Thank you, Chair, and thank you both for your presentations. I think that both presentations really speak for themselves. I think they were very thorough, but I have two questions. One is for Dr. Aiken, and then the other is maybe for Dr. Ganatra to answer. For Dr. Aiken, in your presentation you stated that 54% of women in your study experienced a contraceptive failure and sought abortion access as a result. And I know we've spoke a little bit here about obviously the importance of contraception and how they should be integrated in relation to abortion care as well. But can you speak further to the relationship between contraception and abortion, and in particular the accuracy of the claim in some quarters that in a liberal abortion regime women may use abortion as a primary form of birth control?
Yes.
And then I might just ask my second question and then allow you to answer. The second question then is to Dr. Ganatra. You stated in your presentation that a barrier to safe abortion services is the intentional misrepresenting of health-related information on abortion. In Ireland, many cases have arisen recently where rogue crisis pregnancy counsellors have given inaccurate and misleading information to women. Can you describe a best practice framework for how such services should be delivered and regulated to minimise any further risk of this? Thank you. So maybe you'll go to Dr. Aiken first.
Thank you very much for that question. Yes, as I showed in the presentation, 54% of those women, the majority, have been using contraception at the time that they became pregnant. Now, we know that contraception is not always 100% effective. There's no method that is. Simply isn't one. But if we look at countries, and Great Britain is an example of this, where you do have full abortion services available to most people, you can see that the unmet demand there for contraceptive use is lower than in Ireland. It's half the rate. So if that claim that people would just stop using contraception because abortion is available, and so why would you use contraception, there really isn't any empirical evidence to support that. If you look at Great Britain, look at other countries that have liberal abortion laws, and look at the rates of contraceptive use, they're really higher than contraceptive use in Ireland. So I would say I don't have any empirical evidence to support that claim at all.
Thank you.
Yeah, to add to that, if you look at the graph that we've shown, it shows how consistently abortion rates have declined in Europe from 1990 to 2014. And the majority of the countries do have abortion laws that are fairly liberal. To address your concern about the misrepresentation of information and setting up services, I think the key point would be to have national standards and guidelines which really lay out clearly the responsibilities and how services should be delivered, and how the legal grounds need to be interpreted, and what medical standards are.
Okay, thank you.
Thank you, Senator Ruane.
Thank you, Chair, and thank you both for your presentations. I asked this first question, I suppose, not really because I believe that it's any way attached in relation to women who don't want to continue with their pregnancy or access abortion, but I suppose just because it's been a reoccurring theme over the last few weeks, I would like you to comment maybe on it. And I suppose, we often hear that Ireland is one of the safest countries in the world to be pregnant. Can you describe how we assessed safety in Irish maternity care, and whether we measure maternal morbidity as well as mortality? And obviously, just to re-emphasise, I do see them as separate issues, but I just think because it keeps coming up every week that maybe you are the best person to actually speak to that, so that we don't have to hear it every week. Also, for Professor Malone, in your presentation you said that the Rotunda Hospital provided 10,000 20 to 24 week scans for fetal anomaly, but also that many hospitals do not have the resources for such scanning. If all pregnant women are therefore not receiving that scan due to inadequate resources, what are the factors currently determining which women receive it and which don't? And one final question is just in relation to the conscientious objection, and you did mention that in smaller hospitals that might become a problem. And I'm just wondering what roles you see for integrated services and GPs. And I know you were probably referring specifically to fetal anomaly, or maybe something that has, arise as in relation to a willing mother in the hospital and something that came up on a scan. But if you come back a little bit earlier to say up to 12 weeks and the role of medication and GPs, I'm just wondering how you see someone overcoming conscientious disagreement or objection in relation to somebody that might only be able to access their GP, and obviously now there's waiting lists to come on to another GP, and what kind of issues would that cause?
I might take the first piece on the maternal mortality and morbidity. So the first thing is we actually monitor this really closely, and certainly the 3 Dublin maternity hospitals have been producing annual clinical reports for decades, indeed probably over 100 years or 200 years in the case of the Rotunda. So not only do we have year-to-year information, we can actually plot the trends. At the moment in Ireland, the maternal mortality rate is somewhere between 8 and 10 per 100,000, and this compares very favourably internationally. For example, in the US, which has a much bigger proportion of GDP spent on health budget, the maternal mortality rate is 17 per 100,000. In the UK, the maternal mortality rate is probably about 10 to 12 per 100,000, and similarly in France and throughout Europe. Scandinavian countries, again, about 6 to 8. So while there are differences in developing part of the world, we have actually very low maternal mortality, although there are small differences there. It's not 99% of maternal deaths occur in the developing world, where maternal mortality rates can be as high as 350 per 100,000 in any one country. And that's quite a staggering figure. In terms of maternal morbidity, about 2 women in every 1,000 pregnancies will have a very severe maternal morbidity. So by this, we define particular morbidities like massive obstetric hemorrhage, clot, venous thromboembolic disease, uterine rupture, etc. So we have a list of very severe morbidities, and again, we keep a record of those. And indeed, we keep a record nationally now through NPEC, which is a group based in Cork, which retain national data. And again, we have trends. And if I was to comment on one trend in Ireland, it would be the rise in hemorrhage. And that's what worries me most as Master of the Hospital, is the increasing instance of postpartum hemorrhage, particularly. The other really striking trend in terms of maternal morbidity is, of course, the increase in maternal age and increase in maternal obesity, all of which have significant impact on delivery and risk. And that's, yeah.
Your last question to me, the idea of the role of more integrated services, perhaps at the primary care level and earlier in pregnancy, we would be strong supporters of that concept. We want normal obstetrics to be in the community as much as possible, delivered by midwives, delivered by GPs, involvement of the hospitals, the obstetricians, only on an as-needed basis. And that's the more efficient way to do things. But obviously that then leaves open the potential that I think you're referring to, that what if the local GP has a conscientious objection issue? The Medical Council would be quite clear on this. While doctors are entitled and allowed to have their own personal viewpoints and conscientious objection, there would be an obligation on a doctor to ensure that a patient is not disadvantaged because of your personal view. So there would be an obligation to refer the patient onwards to another doctor, and I would hope that that would be as efficient as possible. Factors that dictate who receives scans. A crucial concept with fetal anomaly scanning is that it needs to be provided to all patients. It is only a minority of fetal abnormalities occur in the setting of a previously affected pregnancy or a patient who has a strong family history. The vast majority of fetal abnormalities occur once off in a family with a couple where they had absolutely no idea that this was going to happen. And you're only going to find those abnormalities if you do the scan equally for everyone. It's not appropriate and not efficient to just take a certain age group or a certain disease category and provide a scan for those patients. That is one of the challenges I think we have in our healthcare system at the moment. In, for example, the RCSI Hospitals Group, which the Rotunda is part of, we have a new programme just rolling out this last month of resourcing fetal anomaly scans for Cavan General Hospital and Our Lady of Lourdes Hospital by having some of our newly appointed staff there. So I think we will see some improvements in that, but it is a major deficit of the Irish healthcare system at the moment.
Thank you.
Thank you.
Thank you, Chair, and thank you both for your presentations. I have 2 questions really, and maybe I'll ask them first before you respond. And it kind of touches on and builds on kind of stuff that's already been talked about, but maybe if we can tease it out a little bit more. In relation to the rogue agencies, and although we acknowledge that they exist, I'm wondering how we move forward in setting a standard in terms of crisis pregnancy counselling. I think they've done a real disservice to the country in terms of information providers that are unbiased and positive positive experiences and have really left women in a fearful space of being able to reach out and ask for help and ask for advice and to be sure that they're getting the real advice and counselling that they deserve in that situation. So I was hoping that maybe you could provide a description of how GPs are trained to give non-directive, impartial information to women, and how that experience and training could be expanded to inform a national regulatory framework for pregnancy counselling to prevent any further rogue agencies existing to manipulate women in that way. I also noted in the presentation that you described the approach taken by GPs to scenarios in which their patient is experiencing a crisis pregnancy. I think your description is really heartening. I think it's very positive and professional and compassionate. But my concern is that despite your description of best practice in this area, that may not be that every woman is getting such high quality support from their GPs. And just based on anecdotal evidence that I've heard over the years, how do we embed your best practice model into our national GP network, and how can we actually monitor that it's being adhered to, and is there any mechanisms currently in place to monitor the experiences of women experiencing crisis pregnancies with their GPs?
Thank you, Senator. Doctors, thank you.
So if I could start answering that, and I'm going to start in terms, the rogue agencies, I don't feel that it is our position to really comment on these, and I might see if Dr. O'Shea wants to take up on that one. But I wanted to just talk about the counselling in crisis pregnancy, and we have clear guidelines on that in our published literature, which is available, in fact, to the whole public. This is not available to members alone. So this, in fact, is available to everybody on the ICGP website. So in terms of the counselling, the three main goals of the process are to establish rapport and gain the trust of the woman in crisis, to help her formulate a clear definition of the problem. And that actually can be a very interesting way, because sometimes perspective, when it's actually talked through, can change, and that's really important as well. And then the third one is to enable her to establish goals for the management and resolution of the crisis. And so then it goes on to describe how you give the woman space, you give her information about all the alternatives that are available, and there's a list of websites at the back of this publication where there can be a lot more information gathered. You give her the opportunity to explore the implications of each of the options. We give the woman the opportunity to assess her feelings and her wishes and her circumstances, and also further supports. And often you'll have the website. Most GPs, the IT development in general practice is really well advanced in Ireland, and most of us will be able to on the website. Here's where you go for this. Here's where you go for that. So then to move on to how the best practice model can then be more uniformly distributed, that's always a challenge of medical education. And so there are multifactorial ways in which we handle this in all areas. So it's through our monthly publication form, it's through email shots, it's through e-learning platforms. All GPs have a requirement to gather continual professional development points, and for example, reading of our guide can be put down as CPD points. So there are ways, and if there is felt to be a need to really take this area and promote this area, again, the college is in a very good position to do that. Do you want to answer any of the other questions?
Moving on, just a very important question. How can we know is every woman and their partner getting best care in these circumstances? It isn't all right to have fuzzy, nice thoughts about that. It's actually quite an important question, and to some extent it's a difficult question to answer with a high level of satisfaction. But in general terms, the considerations are we do always pay attention in our activities and focus in on when patients don't get best care in a variety of different care settings. This is a special care setting, and it's got an additional complexity around it, but it is part of what we do in the college. Quality is built into our key core message and the foundation message of the college. We do understand that patients get suboptimal care if the doctor is unwell, so we have an active health and practice programme run through the ICGP and have done so for many years. It's innovative, so we do look to the health of general practitioners to make sure that they're well. If the GP is stressed or anxious, they are more likely to be peremptory or dismissive or not in good form or otherwise receptive. That's one plank that protects patients. Otherwise, we have features of practice, and we have our practice management programme where patient feedback is built in, where we encourage general practitioners and advise them as part of good practice to solicit and to ask for feedback from their patients. But we recognise that this patient group are especially vulnerable. It is difficult for them to conduct themselves as enfranchised consumers given the experience that they're going through. So simple feedback on its own almost certainly isn't enough. Within college during this last year, we have been formally looking to see what are the additional ways that we can have patients, or really people, involved in our internal college processes. And that's an area that's been highlighted by College Board. And again, we would hope that women and their partners who've gone through this experience may find a voice within college in relation to that. It's important for the integrity of college. And then there are other pieces that are relevant. Again, in all areas of care, we are required to conduct practice audit, and certainly any general practitioner or any practice could choose to select audit activity around this area of care. So there are a variety of mechanisms, but I think none of them are mandatory or absolutely required. But we would hope that given the variety of different options there to safeguard patient well-being, we hope that this group of women, despite the criminalisation of abortion, do not particularly get the thin end of the wedge from the service that we are providing.
Thank you, doctors. Thank you, Senator. Deputy